Hi, my name is Amanda Watson. This is my Module 1 assessment for NM 702. What memories do you want your clients to have of the care that you provide? What things will you incorporate into the care that you provide as a midwife WHNP to ensure these memories are made? I wanted to use PowerPoint so that I could show this visual of the midwife-woman relationship model. To me, what this resembles is a living symbiotic relationship, and it looks like cell division. So in my mind, I see the making of a mother as Rotham described. So this is, to me, it's a woman being born, a father being born, a family being born through this prenatal care experience and through the childbirth experience. The healthcare provider is the most powerful determinant of birth outcomes. That was such a huge statement. I feel like we have a lot of responsibility, but we also have a huge privilege of being a part of this major life transition for families. As I said, Rotham described the making of mothers, and that through the birth experience, women are made. They're strong, they're capable, they're confident, and how we leave that impression in the mind of a mother is through this mutual relationship of trust, where the woman trusts us, but where we also allow her to learn how to trust herself. And that whole concept of transferring authoritative knowledge back to the woman from the care provider back to the woman, where she is a part of a shared decision-making process and where she learns to trust that instinctive, intuitive knowledge within herself with the education and information that's provided to her, allows her to own that authoritative knowledge within herself. So in order to do that, we need to have individualized care models, not a cookie cutter, one size fits all prenatal care model, but we really need to learn who this woman is in front of us and what is the cultural context from which she comes. Is she coming from an environment of fear? Is she coming from an environment of trust in the natural birth process? Is she coming from an environment or a culture that is heavily influenced by media and their perceptions of birth? And so that cultural context that she comes from, we have to get to know that so that we can individualize our care to learn what her expectations are of us and what we expect from her in return. Some of the barriers in general to providing this model of care is the heavy reliance on technology. The midwifery profession, as Akhil Swaran stated, is a high touch profession. So high touch, low technology profession. However, we operate and we practice in high technology, low touch environments. So I want women to remember my touch. I want them to remember me feeling the position of the baby in their belly and measuring their fundus. Those are things that in my own pregnancy, I lacked from my care provider. When I was touched, it was by the wand of a Doppler or, with other medical equipment and not necessarily a provider's hands. So transforming the work environment and really being able to implement the practice of midwifery in those high technology environments is going to be a challenge. Being very conscious of the language that we use, being very conscious of the actions of the care providers around us, the nurses, the other physicians that we work with. Are there things that are so routine to them that actually strip a woman and her infant of that mutually beneficial relationship that they have on each other, taking a woman's baby directly to the warmer instead of allowing her to warm her own baby skin to skin. Those are actions that may be routine to the environment that we work in and may be something that needs to be slowly transformed with our influence. And this brings a question to me of, how do we do those things while still maintaining intraprofessional relationships of respect and that are truly collaborative, where we are not challenging the physicians that we work with or the nurses that we work with, or making them feel as though we are on two opposite sides, but that we're actually maintaining the same goal in mind, which is to improve the outcomes and to maintain normalcy and physiologic processes in our care. And how do we do that also when we have patients that are demanding elective procedures and are so used to this high risk environment that doesn't value normalcy, but that values the concept of risk? They're demanding elective C-sections or elective inductions that may not be evidence-based, and may actually provide more risk and not better outcomes. So how do we influence the culture of our workplaces and the culture of the patient populations that we are around, in a respectful and a harmonious way? Without going over time, I'm going to go on to my references so that you can see them there. And hopefully we are under 5 minutes.